Hi, everybody, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined by Dr. Buse Sengul, a neurologist and neuroimmunologist at the Memorial Neuroscience Institute. In addition to patient care, Dr. Sengul is also involved in research and educating the doctors of tomorrow. I love that, by the way. Today, Dr. Sengul will be discussing fatigue management in multiple sclerosis, and after her presentation, we'll open it up to your questions and comments. Dr. Singhal, again, thank you so much for being with us today, and now I'm going to turn it over to you.
Thank you very much, Debbie, for very nice introduction. And thank you very much for MS Foundation for inviting me. I really hope that this will be a helpful lecture. I prepared some slides, so I will go ahead and share my screen and we will go over the slides and hopefully we will go over some questions together. So again, thank you very much everybody for joining. Just like Debbie very kindly introduced me, my name is Dr. Buse Sengul, and I'm a multiple sclerosis neurologist at Memorial Neuroscience Institute, and very happy to be here today. So we are today going to talk about multiple sclerosis fatigue. These are my disclosures that are really not relevant to this talk and not pertinent at the moment. We are going to talk about multiple sclerosis fatigue. We are going to define fatigue. We are going to talk about what can be the pathophysiology or mechanism that MS patients do get fatigue. We are going to then talk about other potential things that could be interacting with fatigue, such as depression, sleep, other diagnoses. We will talk about how can we diagnose fatigue, and we will talk a little bit about MS medications and if they have any help in this. And then we are going to talk about pharmacological and non-pharmacological approach, and we will talk about potential future directions, and we will conclude, and I will be happy to get your questions. So when we talk about multiple sclerosis and fatigue, so many of the people that are in this webinar or listening to me today online know what multiple sclerosis is. But just to refresh our memory, it's a chronic disease. It's an inflammatory disease. It's a disease that is caused by immune system dysregulation and the immune system causing problems, lesions, scars in the brain and spinal cord that we call them demyelinating, because that's how the nerves are arranged, that the nerve's myelin tissue is taken out in this disease. And when we talk about fatigue, essentially, when we want to define fatigue, and this is a very general definition, it means that it is significant lack of physical and mental energy. And this is perceived by the individual, but also, of course, caregiver or the family members or the loved ones. And these interfere with the necessary activities or desired activities by the person. So unfortunately, this is a very general explanation, and this is not really multiple sclerosis specific, because if we talk about fatigue, I mean, this is different with multiple sclerosis patients, or this can be sometimes extreme level. And this can be even the worst symptom of multiple sclerosis for many of our patients. This can be the reason that many people are actually not even in workforce, or that are limited in day to day, even though their physical disabilities might be in the other spectrum. When we talk about how prevalent fatigue is in multiple sclerosis patients or people with multiple sclerosis, that's how you are going to see in my slides, PVW, that's what PWMS, that's what that means. And when we talk about that, we say that many studies even report up to 80%. So it is extremely common. And it can again cause significant economic burden. It can cause missed work days, unemployment, even cutting back on work hours, and even hospitalizations when the fatigue is very severe. And again, it can be the main driver of lack of quality of life or burden of quality, lack of quality of life in multiple sclerosis patients. The problem is while this is a very, very important topic, unfortunately, our research is still very limited on fatigue and how much is the impact or how much we can help this. And I think that's why we need to increase the conversation about this and talk more about this. That's why I think these conversations, these lectures are very, very helpful. So let's talk about how is multiple sclerosis fatigue different than regular fatigue. So it is not as the same as muscle weakness. So you can have MS and you can be running marathons, but you might still be fatigued and you that would be just different. It might not be just muscle weakness. And it can be also cognitive too. So many people, they wouldn't necessarily have problems with their physical functions, but it would be much more of cognitive or memory or concentration problems or fatigue. And again, this can hamper basic daily functions in multiple sclerosis patients. And this can happen spontaneously at any time, while regular fatigue that people without multiple sclerosis that might experience might happen after a busy day or day with activities. And this can also get worse as the day progresses. It can be triggered by mental or physical activity. It can be triggered by heat or humidity, which many of the MS patients are very familiar with that. It can be triggered by active infections. It can be alleviated by cooler temperature. It can be alleviated by sleep or rest. So let's talk about why do MS patients get fatigue? And we are going to get complicated actually at this point, because to be honest, the larger answer of that question is I don't know. Nobody knows. There are theories out there, and I will try to explain what those theories mean in basic sentences. But unfortunately, MS world or medical world or neurology world still is discussing that. So a couple of theories that I essentially found, especially in big journals, are essentially we have got areas of our brain that take part in motivation or energy, and including, for example, hypothalamus that can be affected by the lesions themselves. And especially now we know that, especially with better MRIs, we know that gray matter can be affected with multiple sclerosis. So you can have lesions in these areas that can be causing directly, problems with these areas and decrease motivation, energy production, etc. But also multiple sclerosis lesions, the white matter lesions, can prevent those lesions to connect together or those areas to connect together and cause energy problems. We know that inflammatory process. So many patients with lupus, Sjogren's disease, other rheumatologic disease, rheumatoid arthritis, they do also suffer from significant fatigue out of proportion to daily activities. So inflammation, we know that the molecules that we create during the inflammation, especially generalized body inflammation, could cause fatigue and could be contributing to this. And of course, multiple sclerosis being an inflammatory disease is not an exemption to that as well. So another theory is network recruitment. What does that mean? So we know, especially with the functional MRI studies, that when we need to do a task, and that doesn't matter what task it is, even if we are not doing any task, we are just in a baseline state, not thinking, not practicing, not doing anything. In patients without multiple sclerosis, if there's one area that is being activated or being recruited, the other areas are not. And multiple sclerosis patients, we know that there can be multiple different areas. So this can create a different type of energy demand and even maybe more problems with the connections or delay in the connections that could explain the fatigue. Another thing is the impaired balance of the task and reward, meaning this multiple sclerosis patients might need much more demand of the energy in order to do any task, and that balance and the reward to get by doing that task can be impaired, and that can be very one of the big reasons that MS patients might complain about multiple sclerosis. multiple sclerosis fatigue. Another thing that this is actually mentioned in one of the psychiatric papers that I thought that was very interesting is metacognitive perspective. And essentially what that means is essentially that is like the philosophical way of like being conscious of being conscious, right? So essentially that's the brain's awareness of the impairment or the brain's awareness of like limitations and how the brain adapts itself to be able to do the activities. And I thought this was very interesting too. And of course, I think this is also another potential mechanism. But we know that researchers, I mean, as a general of all these things in molecular level, certain molecules that we all have in our brain, such as serotonin and dopamine, the balance of these molecules might be impaired, especially with people with multiple sclerosis on their brain. And they think that also in animal models, a molecule called orexin, and that is the molecule that actually causes narcolepsy, and that might be also impaired as a balance too, and that might also be causing sleepiness and fatigue and so forth. So these are all the theories. Unfortunately, the research is still limited, but there's so much research that is still being done. And especially recently we had a conference and there were big sessions about multiple sclerosis fatigue and research about this. So I'm hopeful that soon we will have more explanation about these. So let's talk about other reasons that as a person that without even multiple sclerosis can be suffering from fatigue. And this can be sleep disorders. And the reason that we are talking about is if MS patients are not immune to these problems, and especially clinicians when they are talking about fatigue, and MS patients when they are complaining about their fatigue or mentioning their fatigue, they should also look into these other potential reasons, and they even maybe with the clinicians they should partner and they should be checking these. So these could be sleep disorders, which we will have detailed discussion about, mood disorders, endocrine disease, polypharmacy or other MS or other symptomatic medications, especially our patients with multiple sclerosis need to use many medications that can help with the spasms, with the neuropathic pain, and they could have the side effects of fatigue. Anemia, that's another very important thing, and many people do have anemia because of many people do have fatigue because of anemia, and that should be checked, especially with MS patients when they complain about this. Vitamin D deficiency, vitamin B12 deficiency, and other potential chronic infections that could be contributing to fatigue or that could cause fatigue in any individual, but not just MS patients. So when we talk about fatigue, we need to talk about depression because fatigue is a big symptom of depression. And it is very, very difficult that when we talk to a person with multiple sclerosis or their caregivers, and we are talking about their fatigue and we are addressing their fatigue, we need to be addressing and we need to be talking about potential mood disorders that can be contributing to this. I have a lovely slide here. Of course, this talking the depression or mood disorders is not in the scope of this lecture, but you can see here the typical signs and symptoms of depression, and that can be persistent sadness, loss of interest, trouble sleeping that could contribute, physical aches and pains and fatigue, appetite changes, difficulty thinking, so cognitive fatigue. So these symptoms can be present with multiple sclerosis patients, and we know that multiple sclerosis patients can also have depressive thoughts or depression much more frequently. Even up to 50% of our patients can be suffering from this. So this is very important that we need to be able to take this out in especially to when we want to address for potential options that we can offer patients. And again, depressed patients can develop fatigue 3.6 times more than non-depressed patients in some of the registry studies. And fatigue can also cause depression too. So this is a little bit chicken or egg. While depression can cause fatigue, fatigue can also cause depression when you have got limitation in doing so many daily activities with your family members or with your loved ones. Or again, the things that we talked about in the beginning of the lecture, potentially even like having difficulty with your income or work limitations and so forth. Fatigue can cause problems with mood as well. So another thing that can cause fatigue is, of course, sleep. Sleep disorders, if you cannot sleep well, or if you are very, very sleep deprived, if you don't get good quality sleep, obviously that will be a problem, especially with fatigue. And especially with patients with multiple sclerosis, excessive daytime sleepiness can be a very, very common symptom. And this can be caused by many different things too. This can be caused by insomnia. This can be caused by restless leg syndrome. And this can also get worse with fatigue and depression. So if I was to draw a triangle, fatigue, sleep, and depression, they go hand in hand. And many patients, they can have just fatigue. And some patients do have both fatigue and depression. And some patients do have all three of them. And this is associated with worse quality of life. And especially when we are talking about multiple sclerosis patients, and this is something that our field is now talking, maybe we are talking about three different phenotype, three different type of patients. And that would mean that patients with fatigue, just fatigue, not sleep or depression, patients with sleep disorders, patients with depression, so both with fatigue, and also patients with all three of them. And this is very important because we are going to talk about potential options that we can help the patients with. And if there's a main sleep problem that is underlying, medications or other factors that we can propose for these patients can be very, very limited, and we would need to be conscious of these, and we should be aware, and we should be ruling out an underlying problem, especially something that we can treat very easily. So let's talk about how can we diagnose fatigue. I mean, first starts with just actually asking this, right? So many neurologists that focus on multiple sclerosis, they know how to ask this, or they know to ask it, because it can be a very, very common symptom. But if your physician is not asking you, or your provider is not asking you, I think as an MS patient, please do try to mention this. And after asking this, there are some surveys or questionnaires that they can be using to track your fatigue. And this is much more pertinent in clinical studies, although some clinics do like to keep track of them. The problem with that is, again, coming back to the basic idea of there are so many basic things that we don't understand, or we don't even know how to guide further with multiple sclerosis. We really don't even know how to or which tracking survey or questionnaire is the best. And that's where it becomes a little bit limited, and that's why we have got so many of them that and no clinician has decided what is the most valuable one. But the fatigue severity scale that I put in here is one of the ones that is most commonly used. And again, based on what the scores are, your clinician can keep track of this and can diagnose your fatigue. So let's talk about how can we help fatigue. So, I mean, we already mentioned a little bit about this, but we need to be really ruling out factors that could be contributing to fatigue and other comorbidities. Again, like there can be other health-related reasons that could be contributing to fatigue. And this can be being overweight. This can be having diabetes. This can be having anemia and hyperlipidemia. And with a patient that has something very basic. That can be anemia. There is no medication that can help with that fatigue because that energy demand cannot be provided by the blood, and that is a very important thing. And of course, that is like a very dangerous thing to have long term. So that's why without checking and without recognizing the other potential comorbidities, just jumping to potential treatment options is wrong and should not be done. And other things should definitely be checked. So how about the multiple sclerosis medications? We are not discussing about multiple sclerosis medications today, obviously, but can they help with fatigue? So many of my patients do actually come and tell me I'm on XYZ medication, and since I started, my fatigue is better. Or some of the medications, actually, patients do come and tell me since starting this medication, I feel more fatigued. So obviously we are lacking big clinical studies, and I'll give you some data when the clinical trials were made and they actually asked these questions as secondary questions to patients. There were some good valuable answers, but before I start a disease modifying therapy to a patient, I always remind this, and I would like to remind this to everybody that is joining us today, that with multiple sclerosis medications, while we would love them to help with the symptoms too, many of the times that's not the reason that we start them. We start multiple sclerosis medications to prevent new or worsening disease activity in the brain and spinal cord, and hence we are trying to stop the inflammatory activity. And this is an important expectation, and I tell the patients just expect nothing to be different when you start the medication and when they work, when the medications are active and when they are effective. That means that you stay the same. And that is important because so many of the times patients do not really understand this, and they think that their symptoms will go back and they will go back to the times that they were before starting the medication. And I really hope that in the future we will have a treatment option that can provide us that. But unfortunately, the treatments that are available right now, we do not aim to control the symptoms with them. We aim to control the disease activity in the background. So unfortunately, I see many patients that stop their treatments that were really helping them in the background because they feel like their symptoms are not under control. And I think this is a very important distinction. So again, as I mentioned, most studies do not directly assess the fatigue, but there are some studies that did look into this. For example, ponesimod, which is under the brand name of Pomvery, showed significantly better results in stabilizing fatigue comparing to teriflunomide, which is under the brand name of Obage, but now generic as well. And again, some data shows the beneficial effects of dimethyl fumarate, which is old brand name of Tecfidera. Now we have got bafiratam and fumarate that are similar class, comparing to glatiramer acetate. That is, sorry, not comparing to glatiramer acetate. Glatiramer acetate also did show some beneficial effects, and that many of you know with the name of Glatopa, Copaxone, and so forth. And some data shows also fatigue control is better that are in the patients that are treated with natalizumab, and that is with the brand name of Tysabri, and fingolimod, that is with the brand name of Gilenya, but now also generic. So sometimes your clinician might, depending on your symptoms with this data, might want to prefer some of these medications to treat your fatigue. But again, the points that I made are very important to make sure that we are not just focusing on disease modifying therapies and making and expecting the fatigue to just get better just purely on disease modifying therapies. So let's talk about some pharmaceutical approach. So when we are managing fatigue, we have got some treatment options that can be helpful. And the problem is when you look at the studies, and they actually did big clinical trials looking at these medications in large clinical trials, And the problem is they said that they do not necessarily work comparing to placebo. But many clinicians, myself included, do think that maybe because fatigue can be multifactorial and again, different phenotypes too, maybe the selection of the patients can be very general and some people might have fatigue and some people might have fatigue due to sleep, depression, etc., and might not feel extreme benefit with XYZ medication. So I think that's why it is important for discussion to take place to talk about the underlying pathology and lifestyle changes that I will talk about. They should come next. And if there's still room for improvement, maybe the pharmaceutical approach should be the next thing again to try with the patient. And we have got amantadine, that is one of the traditional ones that is used, and that can be used twice a day. And it is a medication that was first marketed for flu, to treat flu. Then it was adopted in Parkinson's disease or other movement disorders. And we do know that it can help with the wakefulness cycle, and it is twice a day medication, and it can actually have side effects including insomnia, so that twice a day, the second dose should not be taken very late. And the next medication would be modafinil. This is a stimulant type of medication, and this was actually tested in patients with daytime sleepiness or narcolepsy or shift workers, and that really works in terms of waking up the patient. So especially if I have a patient that's the main reason whenever I talk to them is the daytime sleepiness, so modafinil, yes, daytime sleepiness, modafinil can be something that we can use as well. But again, because this medication perks people up, it shouldn't be used before. So twice a day doesn't mean taking it nighttime, but much more around lunchtime or like before 3 p.m. 4-aminopridine, similar to Umpire medications, were also tried. They do help, especially when patients first start the medications with the fatigue. The problem is their strength or their efficacy might not sustain throughout the 4 months. It can be first limiting. So, and also antidepressants can be very important too, especially for those people that have multiple sclerosis and depression. Paroxetine was something that was tried and was found to be especially better with the energy management. And in my practice, I also do use medications like Wellbutrin, for example, that can also help with the daytime energy a little bit more, or even bupropion can be helpful with that too, or buspirone, sorry. And especially if the problem is sleep problems, medications or antidepressants that can help with the sleeping at nighttime can also be helpful as well. And let's talk about non-pharmacological treatment. So actually, this should be something that we should all be discussing about with our patients. And I should have put this slide actually before the pharmacological treatment, but because I really do think that this is much more helpful and lifestyle changes are much more helpful. So cognitive behavioral therapy in clinical studies have shown multiple times that can be helpful, especially with fatigue management with the patients. The problem with this is, of course, it might or might not be covered by the insurance. Finding a therapist, especially one-on-one, can be limited. And finding a therapist that you feel comfortable can be limited as well. But again, cognitive behavioral therapy is one of the very good resources that patients should definitely be looking into. Mindfulness-based exercises, especially if cognitive behavioral therapy is not an option because of multiple limitations we talked about, that can be used as well. Increasing reward. So this is essentially going back to the idea of multiple sclerosis. Fatigue can be caused by balance in reward and task and or energy that the tasks are demanding. So can we increase the reward, like a higher salary or better options or awards. So I wish this was as easy, but like maybe even like again, some of the mindfulness or CBT therapies might even be using these type of things, but I even give these as my patients. Like when I ask them to do exercise or do certain things, I do try to put like little rewards with them or try to put little tasks with them, and that can be a good way for our patients or our caregivers that live with our patients can be looking into. Exercise, very, very, very important. We know that exercise, especially regular exercise, and this is combined exercise, such as, for example, group classes, yoga, Pilates, these type of classes can really, really be helpful with fatigue management as well. Avoiding polypharmacy. We talked a little bit about this. Especially our patients might be using certain agents to help with, their neuropathy, spasms, and so forth. But again, they can be making multiple sclerosis fatigue worse. So, especially if a clinician is looking at you and addressing your fatigue, they should be definitely looking at your medications. And please, please, please try to discuss with them all the vitamins that you are taking or other supplements that you are taking in addition to this that could be contributing into this polypharmacy. And dietary changes, we will actually talk a little bit about this, but certain dietary substances that we might be eating can be contributing to our fatigue. And this happens with everybody, not just MS patients, and that can be helpful to change dietary options as well. Vitamin D supplementation. I mean, many of my colleagues, we do check vitamin D levels. We make sure that patients are on top of their vitamin D supplementations. But if this is not being checked, it is very, very important for vitamin D to be checked and making sure that that is in a level that we would want it to be. And just to remind, for multiple sclerosis patients, we actually want vitamin D levels to be on the higher side, and that would mean at least 40 to 100 or 40 to 90 in blood testing. Educational programs. Actually, there's a research that found out that educational programs such as this, or even like one-on-one programs to talk about fatigue and how to manage fatigue, had been very, very helpful. So that even shows, even if we don't have one-on-one educational programs, even talking to your clinician can be helpful, or talking about even the non-pharmacological approaches. Transcranial stimulation, that is something that we can use, especially in mood disorder treatments, but there's actually some evidence to show that they can be helpful even with the fatigue management as well. And use of technology. So we will talk a little bit about that, but there's so much wearable technology or other things that can put some data together and give you a little bit about your baseline readiness score, so to say, and use of those type of devices, or using a device that can help track your sleep, even if your sleep you perceive that to be stable or under control, can be helpful as well. So we already talked a little bit about vitamin D, but significant reduction of vitamin D can cause fatigue. And many of my patients do actually give feedback that when the days that they use their vitamin D, their fatigue is much better control. And we talked about using technology a little bit, but when we know that patients with multiple sclerosis have fatigue, then keeping fatigue diary, and there are even apps for these, or keeping activity levels, mood status, and quality of life, like these type of monitoring, and even tracking this if this is not something that you can have as a technological device, can be helpful too. And there's actually some new novel research that is looking into even VR and CBT or other therapies that can be given with VR. And that is that virtual reality that can be helpful, especially to help the brain to go back on that balance of the task and reward again. So the diet and fatigue. So diet is one of those topics that unfortunately many of us are very, very interested, but we still have limited data to tell our patients, especially in multiple sclerosis world. There are so many diets out there that there are so many books that many of you can get, and we still don't know which one is better, which one is more beneficial, especially people living with multiple sclerosis. But we know that obesity affects multiple sclerosis. And so we know that certain diets could be contributing into fatigue. But again, doing a diet study can be very, very challenging. So a couple of studies that I was able to look at before while I was preparing to this lecture. Again, there are so many singular and smaller studies that do express that one single diet can be better than the other ones. But the bigger ones that I was able to find show that Paleolithic and Mediterranean diet can be a little bit better. And again, these are retrospective studies, so they are not as ideal studies as we would love them to be. But we know that both of these have high intake of fruits, vegetables, fish, seafood, nuts, seeds, and healthy fats, and avoiding processed food. So if you are a patient of mine, you heard me say that very, very often that trying any diet is very good. You can try Vols protocol, vegan diet, or other diets, but if you cannot try any of them due to multiple different reasons, at least avoiding processed food, avoiding added sugar, sodium, or hydrogenated fats, that would be ideal at least to help with your multiple sclerosis and your fatigue. And again, lifestyle changes. I think this should be the first step for energy management in multiple sclerosis. And that starts with setting realistic goals. Again, I tell my patients typically at least 15 minutes twice a week is a way to start. And if I was to tell every patient you are from now on you are going to go to the gym and work out for 1 hour, that is not going to be a realistic goal, and I would be failing immediately. But 15 minutes twice a week and slowly increasing is very, very important. And when my patients are able to make it and they really put active lifestyle in the forefront and they can do it, they really do come and tell me that their fatigue is much better controlled, their energy levels are much better. So this is something that we see again and again and again, and I cannot stress the importance of regular activity, regular physical exercise, and lifestyle changes. And again, therapist-led or trainer-led classes show benefit. Many of us doctors, we do not mind giving you a physical therapy script. Even if you are fine, you do not have any limitations, getting a physical therapy script just to go to physical therapy or co-therapy, etc., can be very good to start. And you can take it from that point, and you can do your own exercise regimen. And many of my patients, when we talk about this, they do say that I'm always active in my daily life, so I'm as if I'm always exercising. And while that is very, very helpful and very good, unfortunately, that is not enough, because when we are exercising, we would want that focused time that we are working out, and it is not moving around or walking in the hallway would not, unless you are walking for consistent time, would not really count. And for that, the main example that I say, at least 15 minutes, even if you are walking, if somebody was to call you, you shouldn't be comfortable talking on the phone. You should be short of breath. That should be something that we should aim for. And even if you are not able to walk, even if you have limitations in your activities, there are so many different exercises or so many different levels of physical activity that you can do. And we have got many resources. National MS Society has big guidelines, and everybody can look into that. I know there are so many even online classes that patients can do that can be for any activity level. And again, as we talked about, if lifestyle changes do not work, then pharmacological options can be discussed. So overall, to conclude, We need better definitions for multiple sclerosis fatigue. And we need better scales for multiple sclerosis fatigue. There is still not a single scale, as I said, or single diagnostic criteria yet. And we need to use biomarker studies to study multiple sclerosis fatigue better. It would be great if we could check something that, rather than just a subjective measure, we could tell our patients or we could guide our patients. That would be very, very helpful. Again, we live in lucky times. We have got advantage of technology, and I'm really hopeful that we are going to see more and more studies. We are going to see more options with technology, especially to treat multiple sclerosis fatigue and assess multiple sclerosis fatigue. So that is going to be very helpful. And again, diet. I know that many researchers are studying the diet and multiple sclerosis guidance, and that will be really, really helpful in the future, especially when we can help our patients and guide them a little bit better with what diet to choose. But thank you very much for listening to me. I really hope this was helpful, and I'm ready for questions now.
Wonderful. Thank you so much. That really was wonderful. Okay, so let me explain for somebody who has not attended before. I'm going to tell you how to put your questions in, although I did chat it in the little chat session. But if you'd like to make a comment or a question, we're going to put it strictly into the Q&A area. Try to leave the chats area alone. And if you want to ask your question live, you can just raise your hand in the app, or you could even do it anonymously if you like. So if you're on a phone, you just hit *9, and that allows you to raise your hand that way. So, okay, let's see. Let's go back. We have, let's see. I see somebody just raised their hand, but let's go to the other. Do you consider a bout of fatigue a relapse?
So traditionally, no. If somebody has significant sudden fatigue episode, I would definitely want to make sure that there's not a, infection underlying, especially with multiple sclerosis. Sometimes patients might not be feeling their urinary tract symptoms, or again, there can be another chronic infection or another underlying abnormality. If all of these can be ruled out and there's no other physical activity, I would definitely look into MRIs, but if the MRIs do not show anything else, I wouldn't necessarily think that this can be a relapse. But again, I know that sometimes patients being treated with certain immediate treatments can feel benefit with that.
Okay, and does the amount of stress affect fatigue severity for PSMS?
Definitely. So, stress and again, mood problems, unfortunately, they are part of multiple sclerosis factors that make multiple sclerosis and symptoms to get worse. Fatigue is not immune to that. As we discussed, depression and fatigue or any other mood problems, even if it is just a single stressor, they are big, big factors.
Okay, Julie wants to know if she's on Kesimpta, can she also take ponesimod for fatigue, or would she take one or the other plus a fatigue med such as modafinil?
So no, we right now do not recommend using two MS medications at the same time. So Kesimpta and ponesimod, taking both of them at the same time would not be helpful. Kesimpta and ponesimod were not really compared side by side, but your doctor might have reasons to choose Kesimpta over the oral pills, and or other reasons for that preference. But if you can always take modafinil or other medications that can be helpful for the fatigue.
Okay, and do you ever prescribe Ritalin or Adderall for MS fatigue?
I do, especially when I talk to the patients about their fatigue, and if the fatigue is much more mental fatigue and there's problems with attention and concentration or maintaining that, sometimes before modafinil, I even go to Adderall or Ritalin like medications to be able to achieve that. Again, big clinical studies do not say that they do help, but again, for symptomatic management, I still use. And some patients do feel benefits, some patients do have side effects, and sometimes we need to go back to modafinil because of side effects and so forth.
Okay, thank you. If modafinil 100 milligrams didn't work, would you recommend bumping it to 200 or take another med for ADHD? I have tried so many and currently on Vyonese, and it's helping with fatigue until around 5 p.m. Plus, I am feeling very jittery.
So in modafinil, starting dose is 100 milligrams twice a day. I do have many patients that I give them 200 milligrams. And there's a study that, again, looked into 200 milligrams twice a day. Did not feel benefit with that, but some of my patients do need to use that. Sometimes insurance can be a problem because of that study that, it might not be helpful. So some insurances might not approve that. But sometimes a way that I do tell my patients, let's say if they take 200 milligrams in the morning in a day that they have got more physical demands or mental demands, I do tell them to take half a pill, but not be at 5 p.m. because then there will be insomnia like before 3 p.m.
Thank you. Kathy has an interesting question. Does the location of the plaques in the brain, neck, or spine impact fatigue?
That's a very good question, actually. They did look into this in actually a study in Italy, and they do say that the number of the lesions doesn't really predict the fatigue with multiple sclerosis, but where those lesions are, at least based on this first initial study. But this was only the first study, so there will be more, hopefully. But yes, they can predict fatigue. We don't yet know what locations, other than some general idea. But yes, that can be predictor.
And is the term inflammatory in MS only occurring during active immune response, causing lesions?
Very good question. So that is something that so many big MS researchers are still discussing about, because the inflammation that we can see in the MRIs, active inflammation and so forth, some and that happens in the relapses much more. But we do think that there can be still micro-inflammation or even that smoldering inflammation in the brain, even when there's no relapse, even when there's no active worsening, just progression of the disease.
Hmm. Do you find that naltrexone typically is successful with helping with fatigue?
Good question. I do typically use naltrexone for my patients that neuropathic pain medication might not be helpful. I do have number of patients that do feel benefit with that, but naltrexone can also be challenging for some of the patients to get, especially to be able to find a pharmacy and other things to be able to guide. But um, a few of my patients do feel benefit with them.
And Kathy wants you to know that she goes to the gym for 1.5 hours 3 times weekly in the morning, then plans to take a nap after she has lunch. She's 72 years old and also has DM2 and atrial fib. So
Wow, yeah. So I think Kathy, you are doing amazing. So and again, it is all about lifestyle. Like I do tell my patients, I know sometimes our work schedule and other things might not allow us, but if you need to take a nap, take a nap and then continue your day. So you are doing amazing.
I agree. I'd like to take a nap. Okay, so Lisa says, what app for fatigue is out there to track symptoms?
Oh, very good question. I actually, so there was a very good study that I found, but it was a few years ago, so I didn't actually include them. But I think like again, I don't have like any of them in my own chart right now. This is of course I have no financial relationship with anything. I do like my aura ring myself. I personally, again, this is not a medical endorsement, but I do like my Oura ring that gives me a little bit of a baseline information about how I slept, how I feel that day, and if I get sick and so forth. So these are the wearable devices that can be used. Otherwise, I don't know any app on top of my head, but I'm sure like if you can look up fatigue diary or some other like symptom diary, you can find some.
Thank you. And what are your thoughts on stimulants such as Adderall, and are they proven to be effective?
Yeah, so we discussed about this a little bit. Modafinil is technically one of the stimulants, and Adderall and similar medications. In the big clinical studies, we do not have proof that they do work with MS fatigue. However, we know that case by case basis, they can be helpful. Again, before jumping into those medications, we need to definitely make sure that certain check boxes are addressed, such as sleep, depression, and so forth, and other blood testing. And if not, they can be used.
And what are you actually looking for in a sleep study besides sleep apnea that would contribute to fatigue?
Sure, yeah. I mean, like there are so many other things other than the sleep testing that we can find. Like, for example, the sleep apnea is a main thing, of course. We can even like, especially with the big studies, even find the restless legs, and we can even find like the deep sleep levels. And if they are good enough, and what if the patient is still having daytime sleepiness or insomnia. I mean, again, sometimes even narcolepsy and so forth, we can be looking into them.
This person says that Julie said that she knows you mentioned TMS. Are there any concerns with TMS, and is it okay to do that plus working with a psychiatrist?
Oh, definitely. I think especially if TMS is covered by your insurance, please, please, please go ahead and give it a try because I really think that initial studies are very promising. The problem is, of course, they are approved for much more in the depression category, but if you can get it, I think you should definitely try.
And Kathy says for her, pacing herself is the major intervention that she uses for fatigue. Plan her days to accommodate a nap between activities. Don't overdo it. She says, I don't want to take the meds for fatigue due to the side effects and studies questioning their effectiveness. So,
Exactly. Yeah. And to be honest, I had many patients that, we had to get to the medications and they started to have worsening anxiety or worsening sleep problems that we had to stop the medications. So,
okay. And your thoughts rather, on crap gap. Fatigue before the next DMT is due for those of us who are on regular scheduled DMTs.
yes, that is something that we all MS neurologists hear about. I really do think that it is real. It is there. Many of my patients do talk about it. When they do again big studies, they cannot really pinpoint what can be contributing, but we see that with natalizumab. We even see with ocrelizumab, especially with the B cell treatment. There are some options now that can potentially help with that. So please, please discuss with your doctor and potential other options. And with natalizumab, if you are on natalizumab, there might be a reason that you are on it because of the efficacy or your disease activity. And there might not be so many options about that, but still you can discuss with your doctor what else can be done.
And John would like to know, I just lost it. He said, does Mavenclad cause fatigue?
No, actually, I had patients that while they are taking it during the 5 days that they are treatment period, I did hear some fatigue during that time, but not continuous. Actually, some of the patients did feel a few weeks later much better in terms of their fatigue, but again, this was just my own experience.
Okay. How much does being on a DMT impact fatigue levels typically?
As I mentioned, I've got patients like somebody that I saw only yesterday said that after they started their infusions, their fatigue was much better. But I don't want anybody to aim for that. So, um, you expect, especially with DMT, starting a DMT, that fatigue is not going to be different at all. Having said that, again, we discussed about inflammatory activity being one of the drivers. If there's a lot of inflammatory activity and we can stop it, you might find that fatigue is much better.
Dr. Lisa would like to know, when would you order a functional MRI?
Good question. So functional MRI is still not commercially available, at least that I know of. So that is much more in the research studies, and we will see how much that will help in the clinical practice too. Even if commercially available right now, again, we don't know how much they can help with um, clinical decisions.
Okay. Can you talk about perimenopause and I guess perimenopause and menopause with MS and fatigue? Julie says she knows all can cause fatigue, but does perimenopause actually make symptoms worse?
Oh, yes. Unfortunately, that is another thing that, for centuries we know menopause and perimenopause, and studies are still very limited, and MS is not immune to that. I think there's much more attention now, last few years, even in general public in terms of menopause. And I do think that they can get fatigue or similar symptoms, even cognitive fatigue or cognitive symptoms do get worse. And I think, again, we have some data to talk about even maybe hormonal replacement therapies and other things can be helpful. So please discuss, especially with your gynecologist.
Hmm. Can you build tolerance to modafinil? Can you actually be on modafinil indefinitely?
You can be on it indefinitely, but I do see many patients do have higher demands, honestly.
Okay. What are your opinions about alternative treatments such as yoga, meditation, acupuncture, massage, and do you suggest it to your patients?
Definitely. I think they are all very, very, very helpful for fatigue management. So I would always, always, always want my patients to go through that route before we try any medication. And I'm not talking about disease modifying therapies. I'm talking about medications like modafinil, amantadine, and so forth.
Thank you. And this is actually very interesting. Dee said that they found that mushroom coffee has helped them so much with their fatigue. Yeah,
Oh, that's
interesting.
great to know.
Yeah, I don't know where you get mushroom coffee, but it sounds pretty cool. Okay, so can MS affect ANA titer or look similar to lupus? I have positive ANA and several docs thought I may have lupus also. Can MS affect this especially if you have more than one autoimmune disease? Because this person also has type 1 diabetes.
Mm-hmm. Yes, so we do see borderline elevation of ANA with our multiple sclerosis patients. There's when we look at ANA, if it is only borderline or mildly elevated, we might not even consider that very significant. But if it is to a level that your doctors did consider that you might have had lupus, you might do have another underlying disease. And there are certain medications that can help some of them. So I think that should be looked into, and definitely you should follow up with a rheumatologist.
Thank you. Is Provigil a CNS or does it work on the hypothalamus part of the brain?
It works in much more wakefulness area. So like it does work in the CNS and hypothalamus technically. So that's the best way I can answer.
When advertising your lectures, please be more accurate, this person says in the description. I guess that's intended for us. So we'll have to address that after the webinar. I guess what some people thought was going to be spoken about is not. And I guess next time we'll just be more clear in the description as to what's going to be in there. I'm hoping that regardless of what they were hoping to be here today, they still benefited by the content that was provided. And I'm sure everyone did. So we got a whole lot of thank yous and a whole lot of this is information that they're thankful for. So okay, so pseudo shocks from T6 spark every few weeks. Is this a relapse? Only recently diagnosed on terrafluma, ter the terrafluma, you got it. Only 6 months in. Last bout was more frequent.
Okay, so that type of symptom make me think that you have a lesion in your T6 that do get irritated just maybe with activities or just by itself sometimes, and that can be causing symptoms. They are not typically relapses. They are just day-to-day that electrical neuropathic transmission like symptoms. And we actually have medications for that. So please, please discuss your doctor. Teriflunomide is an MS medication, so we don't expect that to help with that shock-like sensation, but there are other medications that can be helpful.
Good. Can symptom cause fatigue?
Um, I don't find that with many of my patients, so most likely no.
Okay. Um, I had insurance lapse on my Tysabri, missing third of my monthly. Um, are there studies on what happens during lapses on their DMT?
So, Taisari, that's a please call your doctor and even your case manager with Taisari because it is not something that you should come off immediately or not bridge with something else. And actually, the company does have very good programs for patients that I do sometimes use. And please discuss with them because you might be able to just get a free medication.
Hmm. Do you feel GLP-1 helps with inflammation, which will then help with patients' fatigue?
You said GLP-1?
GLP-1.
Yeah, so actually, there's some preliminary studies on GLP-1 and multiple sclerosis. They didn't yet study them in actual patients or human beings. These are just in like the lab settings, and they are actually very promising. And so, if you need to be on GLP-1, I think many doctors will not have any objections. Many MS neurologists, I tell my patients to go ahead with them as long as you don't have any other side effects, and I think they can be helpful. And I really hope that we will see more of them in the MS world.
Thank you. Do you see patients virtually in other states?
Please call the number that we have, and we will see what we can do.
Okay, that was cute. Hi there. What do you think about stem cells therapy? Not specifically bone marrow transplant, but other ones.
Yeah, so uh, this terminology is intermixed with some other stem cells that might not be technically controlled or or like in other countries. But the stem cell that in the US that we typically talk about is actually for disease modifying therapy, and that is much more of a to stop the disease activity, especially if the medications are not helping. And that would be taking your stem cells, giving you strong medications to, reset your immune system and giving your stem cells back. That can be very helpful for some of the patients. I've got some patients that ended up getting that route and they are now stable, not on any disease modifying therapy, but this is not yet a practice that we do regularly in the US. And I would really caution people to go to other places that might not be regulated as well.
Thank you. We have one more question that we'll take, and that is, can overstimulation cause fatigue? Great question.
Great question. So I would have to just answer with my own experience, I guess, my personal experience. This is not a medical opinion. I would think so, especially if you are overstimulated and sometimes that can, again, balance that energy demand and can cause problems. And later you might feel fatigue. So I would think yes, but I don't have any scientific answers to that question.
Thank you. This was wonderful. And that brings us to the end of our time. If you've missed any part of this conference, it has been recorded and it's going to be available through the MS Focus YouTube channels. So reply to your registration email for information on how to access those recordings or sign up for our newsletter to learn about any upcoming events that we're having. Our next teleconference is going to be not this coming Tuesday, but the next one, Tuesday, February 11th at 4:30 Eastern Time when Dr. Ben Thrower will be presenting. Um, Actually, that's the wrong one. Okay, Bavia, do you have down what he's doing? Because I have down fatigue management, which is not, this is for today. I just want to tell everybody what we're having. I believe he is talking
He is
about
going
bladders.
to be talking about where's the bathroom, managing bladder issues with MS.
Okay, good enough. That should be quite interesting. Thank you, Bavia. As you leave the conference today, a survey will appear on your screen. We ask that you take just a moment to give us your feedback on the program and your suggestions for future topics. Our goal is to provide you with the best and the most meaningful to you programs possible. Our sincere thanks to all of our attendees that attended today, and especially to our presenter, Dr. Sengul. Thank you so very much for the time that you spent to prepare and to share this information with us. And we look forward to having you again with us in the future. Good day, everybody, and we hope to see all of you again. Thank you.